Yes, I do. Expanders can ride up, they can go lateral. There's a lot of different ways you can expand. You can't always control your expansion. One of the things that has helped us in the recent past has actually been tabbed expanders, because that will hold the expander in place. Before tabbed expanders, the expander would go to the path of least resistance, which typically was the superior chest, and it's actually not the area you want to expand. So I would actually stop expanding patients in certain times and actually take them back to the operating room early on. And if I was able to, I try to place the implant at that time, or sometimes I'd have to put another expander back in and hopefully close the superior pocket. I've tried to do a lot of different things, but it has caused me extra trips to the operating room when I didn't want to. It would. I mean, the hardest part, or the part you want to expand, is the lower pole, and that's supposed to be the area of the most aesthetic part of the breast, and it's always the hardest part to get also. So yeah, it would change things a lot. I'd then have to look at smaller implants. We're actually doing a lot of internal expansion when I was in the operating room myself. But yeah, it made a challenging surgery even more challenging. Like I said, a lot of that stuff's gone away with tabbed expanders. That has really helped. But I mean, part of the thing is you really just want to focus on getting the expander on the chest wall itself. I use a complete either subpectoral pocket where I raise the serratus fascia laterally. And that really kind of controls where I keep things. So a lot of it is really, it's also choosing an expander that fits on the chest wall. I actually tend to not overexpand the lateral side. I don't go off the side of the chest because I think I can release that at a second stage, which I prefer to do. Also, you have more chance of seromas laterally too, so I really don't want to keep expanders over there. So I think that changed, that was really a lot of stuff that I would do. Make sure the expander fits exactly where I want it to. My expanders are all based on measurements. I do all my measurements that I take beforehand are always breast height. My two most important ones, especially for reconstruction, would be breast height and base width. My base width, though, however, is really from the sternal border just to the anterior axillary line. It's not past that area at all. Then what I do is also I can judge based on that what volume I'm kind of looking for after, based on my height and my width. And then what I'll do is I'll tend to choose an expander based on those widths also. In the operating room, I will then also remeasure my marks, remeasure everything, meaning that once I raise up the pec major and once I have everything kind of in place, I will then take a ruler inside and make sure that the expander is going to fit on the chest wall that I have chosen. If there's ever a discrepancy with things, I will actually go for the smaller size expander, knowing that I can overexpand things if I need to, but I'd rather keep things on the smaller side, knowing that I can always do capsulotomies and release things and actually open to put a bigger implant in at the time of exchange. The only time, most of the time, all my surgical planning is based on measurements, except at the time of exchange. At the time of exchange, you do have a volume that you're looking for. So at that point, you then have to see where you're going to fit that volume. So I don't really say I really remeasure anything. I mean, I do check again to make sure everything is where it is. But a lot of times when you're expanding, you sometimes do expand in areas that you don't want to be. So what I try to do is rather than remeasure anything, I actually will do my markings on what I think is cosmetic. I'll do my midline. I'll do where I really want to see my folds, happen to see where I want to place the implants at this time, whether I want to put them more medial or lateral or higher or lower. It's really more of a cosmetic judgment at that time than it is based on base width and the implant itself. This is just seeing from doing it for a long time and doing a lot of patients and knowing the way I like, the way I think things should look, and then also what patients want also. So I let them also tell me when the good part of doing a two-stage breast reconstruction is that the patient has input in this. I always tell them we expand to the point that they say, I'm done and I'm happy with the size that I am. That's why you're not really looking at base width so much as you're really looking at volume, because at that point, they'll tell you, I wish I was slightly larger than where I am now, which is good. But if they say, oh my God, we went too high and it's too far now, that's really hard to do. Or if you expand somebody and they're already up to here and they say, I want to be much larger, then we have an unrealistic thing there, which usually doesn't happen that often. But so it's really, at that point, it's really based on volume, because they're expecting their implants to look at least volume-wise like that. There's obviously fixes that we have to do, but I can't really tell you how long that took me to come up with. It's just been an evolution over time. We tend to just stop the expansion. I'd rather not overexpand in areas where I don't want it to be, because that's harder to fix than it is to keep things smaller and either replace an expander and re-expand, or see if I can open things up surgically in in the operating room, but I tend to stop those expansions if they're not going well. I was having a lot more of those issues when I didn't have tabbed expanders. Now that I have tabbed expanders, it's not really an issue too much. I really haven't had that. And so I can't even think of the last time I've ever had to stop an expansion because of that. Really, tabbed expanders for me changed my practice. It just made things predictable and easier, and I know where things are placed. So, could there ever be a time that the suture breaks or something happens and it moves? That could probably happen. I haven't seen it, but I also think that if you sit things down where they are and then you do suture them, even if the suture breaks, but there's a certain point where things aren't going to move too much. So, I really haven't had that issue recently. I think predictability is always what we're looking for. Like I said, what tabbed expanders do is made it predictable. It's going to sit exactly where I want it to go. Then the second thing you start looking at is, what can you control the expansion? Are there areas you want to control? And there's another company that tried coming up with a dual chamber expander. Practically it doesn't work, but it was a good idea because what they're trying to do is you're trying to control where you want the expansion. So that's always the hardest thing, because even if you have an expander that's in place, you can't control when you're just putting fluid in something where the expansion is going to happen, superior, lower, lateral, medial, and that's all based on external tissue forces. So, I think predictability is really what you're looking for. Well, a few things. It would make things a little bit easier in a way because you also know what you're looking for in terms of lower pole expansion. That's what you're looking for, and especially nowadays as we're getting into shaped implants and really matching things and matching what people's expectations are. I think that will make it easier versus expanding in whatever areas, making things more round and then trying to put shaped implants in. If somebody's looking for round implant, then it probably doesn't make a difference either way. But as we're trying to become more aesthetic, I think that is important there. I think it would make things a lot easier. Now, there is one harder side to that, and that is when I'm doing nipple sparing mastectomies and where I'm keeping the nipple and how I do things. And I do a lot of mastopexy and deep epithelializations and other things like that. So I have to actually think a little bit more now and actually plan on where I want my expansion to be, where I want the nipple. Now you have to start worrying about, am I going to expand? The nipple's going to end up too high. So yeah, you actually have to do a lot more planning for something like that. But in reality, most of us do that anyway. But I think if you kind of know where expansion is going to be, if you have something that's controllable and you know what your lower pole arc is and you know how things are going to come out, it may even make that aspect of it easier too, because then I know where my inframammary fold is, I know where my lower pole arc, I know where I want the nipple to end up, and so it may make things a little bit easier also. Yes and no. I don't think, in a bad way, I don't think patients always understand what they're undergoing, even though we try to explain to them what expansion does and all these things. So I don't always know. However, if you did have something that was more controlled and you were looking at expanding the lower pole and it was going to be more aesthetic, and they could actually see that happening for themselves, then I think it would make their time a little bit easier too. Sometimes things do get a little round or a little bit, and then they say, wow, what is going on here? So I do think it probably would make their experience a little bit easier. With round implants, again, I don't think it matters as much. I think you're going on volumes and widths, and you can kind of even, we could always squeeze a larger thing into a smaller pocket. I don't think it matters as much. My practice is really going more towards shaped implants and being anatomically correct and also fitting where the chest wall is. So I think that would actually make things a little bit easier as we expand things out now, and we can actually see, especially if we can correlate the expander and the expansion to an actual implant a little bit easier. I think that's one way to go. It used to be before that you would just expand things out and it was going to be round, and you say, okay, I have 500 cc's in there, I can put 550 round in, and made it easy. Now you really have to look at the dimensions. You really have to get the implant to fit where everything is going to be. So I think controlling the expansion is probably the most important part of that now, and then getting an implant that fits in that area would be great also. Probably a little bit different than most people in the country. I don't use a lot of ADM. I've had a lot more complications when I use it. So my expanders tend to go in with about 30 cc's of fluid a day of surgery. I want things to heal. I tell people they're going to be flat. It is a little hard to get people to tell them they're going to be flat for a few weeks after, but for me, I'd rather them be flat for 3 weeks than have a nipple loss or skin loss. So for me, that's my most important thing. A lot of people are different nowadays than what I do there. I usually I let everything heal for about 2 to 3 weeks, and then we start expanding out. Because I leave the skin kind of loose, I tend to expand pretty rapidly, but it still takes probably a few months or something like that. If I have to, I have gotten people where I've gone through rapid expansion, where I usually have 8 weeks from the time of mastectomy till the time they have to start chemo or radiation, and I try to get the permanent implant before that. So we will try to rapidly expand people. Starting at 2 weeks, try to put in what we can, and by 6 weeks, hopefully have the final implant in. So 2 weeks to heal, and then they start, radiation or chemo and stuff. So I try to do that if I can. Mentor's new implant or new expander. What I do like about it, like I said earlier for things, I like tabs. I think tabs are really important. I think the most important thing is getting it and putting it exactly where you want it to sit. That's most of the predictability, so it doesn't ride anywhere. It doesn't go lateral, especially if you measure for the chest wall width and height. The other thing too, which I do like now, is that it is really expanding the lower pole. I mean, that is the most important part of this. What we're trying to always do is you always want a lower pole fullness, and especially as we go to shaped implants and things that are more anatomic and more aesthetic, this is really an important thing. And the fact that you can even overexpand this and it's really going to stick in that one area is important. There's no other expanders that I know of that really focus on lower pole fullness or lower pole expansion. Obviously, everybody has more silicone or whatever down here in order to expand lower pole, but in truth, once that gets compressed with forces, it'll expand the upper pole, can expand lateral or medial or wherever. So I do like this. This does really seem to give you controlled expansion, which I think is kind of the most important thing nowadays. So I think this can give you some predictability. I think it's going to take a little while to get used to, in a way, and then I think it will be important for us to correlate what the expander, what implant it goes with, and kind of what we're looking for. But I do think once you get that system down, I think it's actually probably a really nice device to use. The one thing with the Mentor expanders is that they are. It's almost like when you first start using the shaped implants, you don't have any wiggle room at all. Like, you have to get it exactly right. The same thing with this expander. So this one has to be exactly where it fits. With the other expanders that aren't as firm and aren't as solid, good and bad with that, is that I can get a little bit more lateral, it can be tight a little bit, it can expand. This one you really have to pick exactly. So, I think the first few times I use it, I'll probably have more sizes. I don't know what the sizes and volumes and everything are yet, but I'll probably have more sizes available. And actually, again, I'll measure and pull the one off that I would probably use. But I'd have to see that, because that is really a tough thing. You can't, like, laterally just have a little bit pushed in. I mean, it literally has to sit exactly like this. So, whereas the other implants aren't always like that, or extenders aren't like that. As long as you can get that to fit on the chest wall, I think the rest of it kind of takes care of itself. So, and then the heights, most people fit into a sort of probably a moderate or whatever. I'm sure you'll have full and low and stuff, but I think you'll probably won't need to use low ones anymore, because everybody was doing that because they just want a lower pole expansion. That was the whole purpose of that. So I think if you really have one that fits exactly what you're looking for, and as long as it correlates to an implant that you're looking to use, I think it makes a lot of sense. I do think, however, though, when using this is made to fit for an anatomic implant. So you do have to start educating people about shaped implants then and the anatomic stuff. I think that's going to be sort of the whole education process also, because using this to put a round implant in may or may not always make sense. So it still does a little bit, but I'd have to still see it.